So anatomy, this is probably what the bulk of your learning will be uh, in the later half of the year. And essentially, you'll get to do some type of dissection or cadaver work. And it's a really like, how do I, what was it? It's a really uh, privileged, that's the word. It's a really privileged position because these people are volunteering basically their bodies up for medical students to study, right? So it's really privileged that we get to see them and use them. So for that reason, and also for you to get as much out of these classes as possible, it's really, really good if you do some study beforehand, particularly just learning the terms and figuring out what's going on. Because in all of the textbooks and in all of the things will look different to what in your thought it looks like, right? So it's really important that you kind of first know what the most common type of configuration for, let's say, a shoulder or a hand in what like what's the most common type of things in in the hand and like how do they work and where do the vessels pass and all that kind of stuff, right? That's really important for you to learn um, early so that when you learn that in the hand and you've looked at a lot of pictures online, now if you go to a real hand and look at it, you're like, oh, okay, so I remember this goes through here, so I can identify that there. Because in a real person, right, everything looks the same, like the nerves, the blood vessels, everything looks the same. Because in our like in the pictures and in the flashcards, things will be like brown and blue and red. Like it's not going to be like that in real life, right? So you need to know your basic landmarks and terms. Um, and that way, if you ask the people who are doing the dissections with you and you tell them, oh, okay, I think this passes through here. I looked it up and I saw this. They'll also be more willing to tell you, oh, yeah, yeah, absolutely. This is what's going on. You're right. Normally it does pass through here. This one's actually a bit different. And they can tell you more about it. But that's my top tip. You should prepare in advance, especially for anatomy classes. Uh, Make sure to be respectful during the process and ask questions about any structure you don't understand. So it's really important to ask early and don't be afraid to ask as well because a lot of the structures can be really confusing and it's really tightly packed together. So it's hard to know what's what. Knowing the anatomy, especially for the musculoskeletal system, can be really helpful for clinical skills part of the course as well, because you need to know the innervation of the nerve group or kind of what's going on to help you predict what's going to happen to the body, right? So, for example, if I injure this nerve, which helps control this muscle, what is it actually going to do, or what is this person going to complain about? So it really helps you, especially for musculoskeletal and which are like bones, muscles, and the neurological system, so all the nerve system. Those two components, especially, knowing the anatomy really, really does help. Knowing the anatomy for other things, like it's important. Like abdo, like the vague position of the organ is important. But otherwise, like unless you're going to be doing you're in a surgery or something like that and you're looking at it, it's not that helpful to know like each specific detail, right? You just need to know key things and you'll retain that knowledge when you go into clinical years as well. But there's just those little key things are important to figure out first. Cool. So let's kind of, these are some concepts which come over again and again. And these also come up in like radiological things as well. So radiological things are like X-rays, CTs, MRIs, ultrasound. That's what radiology is because in the old days it was purely based on radiation, right? So there's a couple of different planes and each thing will be named a different thing based on what radiology you're taking. But it is useful just to know the planes in general so that you know what you're looking at. So we have something called the sagittal plane, and that goes all the way across your head. And how I kind of think of it is like, I'm not sure why, but like if I think of a sagittal plane, I think of like a Trojan, with the like little hat, not the hat, but the thing that like the little horse hair thing in the middle of their heads. And I kind of think of that, so it goes straight down the middle. If we think of coronal, right? This is your crown, the top of your head. So it has to go this way. And it's kind of like slicing. Oh, sounds a bit gory, but it's like slicing behind your face, right? So that's the slices you'll see. And then there's also transverse and axial, which is like going across your body like this. And it takes slices like that. And it's really useful because if you want to say, let's say if we want to try and find a problem here, we might be looking at here and then we can find it here and then we can also find it here. And it kind of helps us form a 3D construction of the problem that's going on. And it'll be really useful when you look at CTs, MRIs as well, because it gives you a greater sense of what's going on. Another thing that will be important, especially for the bone muscle topic, is about movements. So, and about what is flexion, what is extension. So, the basic movements that we can talk about are is flexion, extension, abduction, adduction, internal rotation, external rotation, pronation, supination, and inversion, eversion. Okay? Not all your joints will be able to do all of these. And in fact, I don't think there's one joint which is able to do all of those. But most of your joints will do, or what most of your joints will, all of your joints will do at least one of these. So flexion extension, what we think of, like there's something called the anatomical position. This is the anatomical position right here. So you have your hands to your sides and then your face standing face on, right? And all of the movements are based on the anatomical position. So if we're thinking of flexion extension, right? So flexion is going to be kind of coming, yeah, it's going to be like going away from the body, right? Or kind of feels like it's going towards the body. Flexion. Yeah, it's going towards the body, I guess. Yeah. So if you think of flexion, it's going towards the body, extension going out, and then flexion of the legs is going in, going out. And that's extension. So that's flexion, extension. That's a paired one. Abduction, adduction. How I remember abduct is away from the body, adduct is towards the body. So if you think of these two hands being brought towards the body or away from the body. So abduction, abduction. Okay. So then you have internal and external rotation, and that's relatively straightforward. So you look at the part which is internally or externally rotated, and does it turn inwards or does it turn outwards, right? So that's how we work out that. And then supination, pronation, you really only see this with your hands because your hands are the only thing that supinate and pronate. Soup, you're holding a bowl of soup, okay? Supination, pronation, supination, holding a bowl of soup. And the last one, eversion, inversion. So the only context I've really heard this in is like your feet. So inversion, you're turning in, eversion, you're turning outwards. Okay, so the soles of your feet are facing outwards, and that's basically the the movements in a nutshell. But each of the joints will have a different set of movements. So for example, in your elbow, right, you are not going to be able to, because your elbow is like because of the way that the joints are connected, right? You're not going to be able to supinate and pronate. Oh, sorry, you're not going to be able to abduct and adduct, right? Because like your joint simply does not go that way. Like if you hold the top part here and try and move it to the side, it's simply not going to go that way because like there's no way for the shoulder. Compared to the shoulder, right? You can add abduct and adduct, like that's possible, and you can also flex and extend. Compared to this one, you can only flex and extend, really. So it kind of just depends on how the joints are connected and what movements you can do. Okay, there is also something called dermatomes, which are really nice and they help you like determine a lot of things. There's dermatomes and myotomes. So dermatomes is like sensation, what you can feel. Myotomes is like the movements you do. Search up if you have time and if you want to, the myotome dance. It's quite hilarious and a lot of fun, and it helps you remember the myotomes as well. And dermatomes kind of just tell you, so these C1, C2, all that type of stuff is talking about the levels in your spine. So the levels in our spine start from C1. So that's for cervical, which we call the region behind our neck. And then we have thoracic. So our thoracic region is our chest region, right? And then we have our lumbar, which is our lumbar region, so the lower back, etc. And then we have the kind of sacral region as well, um, and that's to do with the essence, right? So essentially, for the upper arm, we focus mainly on the cervical spine because that's where all the nerves that control our arm come from. And you can see here that these nerves kind of section off certain parts of the arm. There's also going to be certain, so depending on what nerves you're talking about as well, there's going to be specific sensation areas as well. But it's really useful if we can, in a context of like a clinical patient, in a patient that you might be like, because a lot of the questions, even in preclin, they're focused on a patient does this, a patient does that, etc. So say if a patient lost sensation somewhere and then they had weakness somewhere, you could be like, oh yeah, I know that movement is done by the C6 nerve, and they're also lost, oh sorry, C7 nerve, and then they've lost sensation, let's say, okay, let's say for changing things up. Let's say they've lost sensation at the top of their arm, which is the C5 nerve, and they also cannot shrug their shoulders and cannot kind of lift their arm at all. So what that's related to is the axillary nerve, and the axillary nerve kind of innervates this muscle up here. It helps you shrug shoulders, move your shoulders, lift your arms, etc. And the area here, if it has no sensation, that's also related to the C5 nerve, right? So it's kind of like two things are related in one, and you can kind of use that as your puzzle piece to what's going on.